And then I'm going to hand it over to Dr. Locke. Thanks so much for being here.
Well, thank you guys all for coming. Again, I'm Dr. Locke, and I'm the urologist here. I've been here for about a year now, and I'm loving Tahoe. So thank you to all of those I do know for the warm welcome. And for those I don't know yet, hopefully I'll meet you soon. Today I'm going to be talking about enlarged prostates, which is one of the big areas of urology that I cover and enjoy taking care of. Just a little bit about me. I have a young family. I have two kids, Taylor and Jacob, and my husband Robert's an anesthesiologist. He's still in the Air Force, but hopefully going to be joining me soon the end of the year. I'm originally from the East Coast. I grew up in Massachusetts. I went to Vassar College in New York for undergrad, and then I went to the middle of the country for med school and University of Louisville, and then went back to the Northeast for for residency, excuse me, at Mount Sinai. I came out to California to practice in the Air Force, and now I'm here to hopefully for good. So BPH, what is it? BPH stands for one of two things, either benign prostatic hyperplasia or benign prostatic hypertrophy. Pretty much the same thing, just different words. And what that means is that your prostate, which is a gland that males have, grows in one way or another, whether it's externally or internally, and it's not malignant. It's not a cancer. It's not going to affect your longevity per se, but it does affect your quality of life. And this is something that occurs as you tend to age. So there are different ways that your prostate can grow. As I mentioned, it can grow outwards, it can grow inwards, it can grow forward, and it can grow up into the bladder. And that can kind of manifest itself in different ways and cause different types of symptoms for each patient that can either be tolerable or bothersome. So how can it affect your life? Symptoms that I typically see in patients with an enlarged prostate, I think the most common thing that people think about is a weak stream. So it's taking longer for you to pee. I'll have men say, oh, I stand at the urinal for 5 minutes. Or you feel like you're just not emptying your bladder. It feels like there's some left over. Sometimes it takes a while to start your stream, and that's because it requires pressure from your bladder to start to empty. And so it requires extra pressure to overcome that blockage from the prostate. And so it just takes a little bit more before that stream can start. Sometimes it will make it so your stream kind of starts and stops. So you might pee a little bit, have a break, get a little bit more out. And all of these things can be really frustrating for patients. If you don't have your prostate treated, it can lead to changes to your bladder. So this bottom image is what a healthy bladder looks like. You can kind of see that it's smooth. Yes, we see some blood vessels here, but it's nice and healthy. But if you look at the top picture, this is of course an exaggerated or a very severe example, but you see that there's a lot of changes. These kind of ridges here are what we call trabeculation. And what that is deposition of collagen that is not elastic. And that's an irreversible change that happens to the bladder. We also see that there are these out pouches here. We call those diverticula. And that diverticula you can have in your bowel, you can have in your bladder, and that's where there's no muscle surrounding the mucosa there. So the muscle is what squeezes to help your bladder empty. That part of your bladder no longer has something to put pressure on it to empty the urine from it. These changes, again, get worse over time. So this is a bladder that probably has been working against an obstruction for years. But the longer that you put your symptoms off, the more likely these changes are to occur. And when this happens, it can lead to more irritative symptoms where you have to go to the bathroom more urgently, meaning you just don't have time to make it, or you have to go more frequently because now your bladder is not as elastic, so it cannot distend, it cannot fill very well, and so you're going more frequently. Another reason why you might go more frequently is now here's our happy empty bladder and here's our sad full bladder, and maybe you're not emptying yourself fully. And so you're here in the middle. Well, if you don't empty yourself fully, you have a lot less time before your bladder is going to be full again. So that time that it takes to fill your bladder is less. You're going to have to go to the bathroom more frequently. Some risk factors for BPH. I think the number one risk factor that we all think about is age. About 50% of men by age 50 do have signs and symptoms of BPH. There is a genetic component, so if your family member had prostate issues, you may be more prone to having prostate issues. There's been some association with obesity and diabetes. Hormones is a big thing. Sometimes when we put patients on testosterone therapy, you may see an exacerbation in your urinary symptoms afterwards. So the prostate is made up of cells that actually convert testosterone to a more potent steroid. So the more testosterone you have, the greater the chances that you'll have an enlarged prostate. And then of course, diet, having a diet that's not great in antioxidants is going to make you more at risk of BPH and then inflammation in general. So there are a multitude of treatment options for BPH. And I think that when you start with your primary care doctor, they're going to start with you on medications. And then when you come to see me, we'll kind of talk about both options, medications and interventions that you can do. There's not one way that you have to start. You could be 50 and come and say, I never want to take a medicine in my life, and have a treatment for your enlarged prostate. And you could be 85 and say, I never want to have surgery. I'm going to stay on medicines for the rest of my life. There's 3 classes of medicines that exist. They're the alpha blockers, which I think are the most widely known. That's Flomax, and that's what I think we start most men on, though there's multiple different drugs within that class. And those medicines work by relaxing the muscles in the prostate to open the channel wider. There's also a class of medicines called 5-alpha reductase inhibitors. Finasteride is the most common medicine that's prescribed from there. And I think it used to be prescribed more frequently. It works by shrinking the prostate. It actually blocks that conversion of testosterone to the more potent steroid. I think the hesitancy or the drawback to use that medication now is that it does cause some sexual side effects in patients, and so, or some sexual dysfunction, and it's kind of crummy to maybe treat one issue but cause another. So I think a lot of urologists at least are quite hesitant to use that medication now. And then lastly, some people will prescribe a phosphodiesterase 5 inhibitor or PDE5 inhibitor, which is Cialis. Classically, that's a medicine for erectile dysfunction. It kind of works similarly to the Flomax. It relaxes the smooth muscle, hopefully opening that channel. And studies have shown that it does show a minimal improvement in patient outcomes and how they feel they're doing. So I do try that for patients who don't want to have surgery just yet. And then as you can see on the other side, there's a lot of procedures and interventions that exist now for an enlarged prostate. And they can be done anywhere from in the office to the operating room as an outpatient to requiring an inpatient stay. So I'm going to go through those treatment options for you today and kind of talk about the risks and benefits of each. Oh, and then here's a little bit more information about those medicines. So again, those alpha blockers relax the smooth muscle in your prostate. And then some of the side effects that we do worry about: low blood pressure, which can make you dizzy. Sometimes it causes a runny nose. And then that kicker that most people dislike is that retrograde ejaculation. And that's where you ejaculate. You can have an orgasm, but nothing comes out. So it's dry. And that's because the ejaculate goes backwards into your bladder, and then you pee it out later. Like I mentioned, the side effect to the finasteride is that it can cause sexual dysfunction. Some men will also have some breast enlargement and tenderness. And in some patients, those are reversible. But in some patients, we've now learned that those are irreversible changes. And then for Cialis, that's not an option for all men. If you do have a cardiac history, we cannot prescribe that for you. You cannot take nitroglycerin if you're on that medicine. So it's something that we need to be a little bit more mindful of, and it can also drop your blood pressure a little bit. And then if you're on both Flomax and Cialis, you have to take them at different times of the day, or else they can kind of make your blood pressure bottom out. So for surgical interventions, we can kind of break them up into two categories: minimally invasive and robotic surgery. And the majority of them are minimally invasive, which is wonderful. Again, some are I used to do in the office, and some are quick in the operating room. There are some new procedures that I'll kind of touch on. There's not much information or much data behind them, but we'll see kind of how they do over the next couple of years, and maybe we'll adopt them here at Barton. So Rezum is a steam vaporization of the prostate. And this is a procedure I used to do at my last hospital. It's essentially where you have a cystoscopic procedure. So all of these cystoscopic procedures are where I take a telescope camera, I go into your bladder, and then I treat your prostate through the urethra. So you can see in this image here, this is the telescope camera. And for this procedure, they have this little injector that goes into the prostate and it injects steam. Each time this is put into the prostate, it's a 9-second treatment, and then it kind of goes back within the scope. And we do at least one injection on each side. Some prostates may require more than one. And then some people will develop a lobe that kind of grows out towards us in the screen here, and we may inject there. So the benefit of Rezum is it can be done in the office. You do not need anesthesia for it, or it can be easily done at an ambulatory center. And I think the biggest selling point is that it can preserve your sexual function. So patients do not experience that retrograde ejaculation in the same way with this procedure. Because we don't do anything to stop bleeding, and because it doesn't remove any tissue, it requires that the tissue kind of dies and sloughs off. There's a lot of swelling afterwards. And so you actually need a catheter to stay in for 3 to 4 days, which is longer than the majority of the other procedures. I do find that these patients had a longer recovery. So all cystoscopic procedures have this risk of burning when you pee. And I found that patients who had this procedure have burning for a strong 4 to 6 weeks, whereas it's a lot shorter with other procedures. So some great positives and then some drawbacks there. The UroLift is something that I believe Dr. Seixner used to do here at Barton. I have not opted to adopt this, but this is essentially, again, a cystoscopic procedure where staples are used to open the prostate. They create that radial pressure to make the channel wider. I think the big benefit with this procedure is it does not require a catheter afterwards unless you're unable to urinate. But the drawbacks are it can affect MRI image quality. So if your PSA becomes elevated in the future, I typically order an MRI to look for prostate cancer, and that may not be as easily reviewed by a radiologist because of artifact from those staples. Again, if you have that lobe that kind of grows out of the screen here, that median lobe, this is not a great option for that. I think that the company that makes UroLift, they're trying to argue now that you can treat those patients, but I don't think it's really recommended. And it is limited to smaller prostates. So it's not great for men who have a prostate on the larger size. So the next procedure here is a TURP, or most people refer to it as the Roto-Rooter. And this stands for transurethral resection of prostate. This has classically been the gold standard treatment for BPH in terms of surgical intervention. It's been around for decades. And essentially what we do is we take a telescope camera, again, through your urethra into your bladder. And this is kind of this U-shaped device here. And we use it to carve the prostate out. So it's more like whittling away at the prostate until we can open that channel up, again, to make it wider. I think a big benefit of this is it's definitive. We remove that tissue at the time of the procedure. So you do not need to wait for any, tissue to die, for swelling to go away. There's going to be an immediate improvement. It lasts on average 5 to 10 years. So there is good longevity with it. My goal in any of these procedures is to have you off of medicine afterwards. The drawbacks, you do need a catheter afterwards. I typically leave one in for 1 to 2 days, depending on your situation and how the surgery goes. And then again, it does have that retrograde ejaculation. And just to kind of drive that home, the ejaculatory ducts are kind of right in the middle of the screen here. And so when we carve the prostate out, we open this part up right here. So the bladder neck, this is the bladder, this is where the prostate meets the bladder, is wide open. When you're trying to have intercourse, your sphincter, which is over here, is engaged because you don't want to leak urine. And so that ejaculate kind of goes to the path of least resistance into your bladder. And I do the TURP at Barton. So the next treatment here is aquablation. And so this is a newer technology. It's been around for probably 6 years now. It was just being studied when I was in my training at Mount Sinai. And what this is a high pressure wash that kind of carves the prostate away from those water jets. It is technically done robotically. So there is an ultrasound probe that goes in the rectum during the procedure. You're asleep. And we map out your prostate on that ultrasound image and determine what portion we want to remove. Then this again, high pressure water kind of carves the prostate out. And afterwards, we just go back in with a telescope camera and make sure that there's no bleeding. Again, this is a definitive surgery, so that is a pro. We're removing a significant portion of the prostate. For men with larger prostates, this is a really great option. There are some men who I can sit and carve away at your prostate for 1 to 2 hours, and it will definitely make a difference, but an aquablation can cut down on that operating time to maybe from 2 hours to 1 hour, or from 1 hour to 30 minutes. And that's significant because while it is scary to go and have a procedure done through your urethra, I'd say the biggest risk with any of these surgeries in the operating room is the anesthesia. And so if we can cut down on that, that's wonderful. The drawbacks to it, because this is newer, there's a little bit more bleeding with this procedure. Most urologists at this point in time do keep patients overnight. It does, again, require a catheter. Usually that stays in for about just the 1 night. And then there is that possibility of retrograde ejaculation with it. This is technology that we are looking to bring to Barton in the future. So I'm very excited about it. And then there's HoLEP. So this is also kind of a newer procedure. I'd say maybe it's been around for the last 10 years. And I do think this is the future of urology. And this is essentially, it stands for holmium laser enucleation of the prostate. So again, the cystoscope or the telescope camera comes into the urethra, into the bladder. Once we find the prostate, a laser is used to kind of core out the prostate. It's almost like it's an orange, and it's separating the inner part of the orange from its peel, but on the inside. That then inner part is pushed into the bladder. It's broken up so it can be removed from the body just through a telescope camera, and then it's removed from the body. This is great for any size prostate, which is a positive. So if you have a really large prostate, it's not going to really affect the operative time that significantly, because again, it's just that coring out, and the breaking down of the prostate gland is quite fast. It is, oh, sorry for my typo there. It is the most definitive procedure that we can do endoscopically or cystoscopically, because again, we're getting to that very edge of the prostate or the very edge of the core and removing all of that tissue. The drawbacks, this is really not widely available. Nobody was doing it where I trained at Mount Sinai 5 years ago. Within a 2-hour radius, Dr. Cambasser does it at UC Davis, and I just learned this week that there's another urologist that offers it at Stockton. We just acquired the laser that allows us to do this procedure, and I'll be going to a course in September to learn how to do it, but it does have a steep learning curve. So I'm not sure if or when I'll be adopting it, but it's something that I would need to make sure I really felt comfortable with before I started operating it here. Most patients do stay in the hospital overnight afterwards. It does require a catheter, and it does cause that retrograde ejaculation. And again, same idea. We're kind of really opening this up widely, and so it just allows that ejaculate to go back into the bladder rather than come out. So another option is something called a simple prostatectomy. This could be, in theory, done open, where we make a big incision on your belly, or most realistically, robotically. I don't know that anybody would really offer that anymore. I last did one 3 years ago. I don't think I would suggest it going forward. But essentially, it's the same idea as a HoLEP, except we're entering your bladder through your belly. So we use laparoscopic instruments that are kind of like chopsticks. They go through your belly and into your pelvis, and we'll kind of open you up a little bit, whether it's your bladder or your prostate. And again, we core out that inner part of the orange, that inner part of the prostate, and then we sew you back up. And this was the best way to treat large glands until the HoLEP came around. Because again, a surgeon could be in there for a really long time trying to treat this endoscopically. And if we were to do it robotically, it's just, we can be so much more effective at what we're doing. A big benefit to doing a robotic procedure is if you have large bladder stones, or you have a very large diverticulum of your bladder. Some patients have this big outpouching that holds maybe half a liter of fluid in it. We can kind of treat that at the same time, so you're not going to have this really long surgery, or we don't treat diverticula other than in this setting. So that may improve your urination in the future. So that's some strong benefits to it in the right patient. The drawbacks are that you're definitely staying in the hospital for at least one night, and that catheter is going to stay in for 7 days. And that's because we had to open either your bladder or the peel of your prostate, that outer part, to access the inner part. And so that needs to heal. And it takes about 7 days for us to feel confident that's healed effectively, for us to do it. Also, you have to recover from surgery where you had small incisions. So it's just going to be a little bit of a longer recovery. I'd say from a cystoscopic procedure, every patient's going to experience that burning with urination. It will probably last for 1 to 2 weeks for the majority of patients. For a HoLEP, for a TURP, again, a little bit longer for the Rezum. But you're not going to have to deal with significant pain. I don't prescribe narcotics for patients after my cystoscopic surgeries. I've never had someone call me and ask for a narcotic afterwards. And with this surgery, you may need that. So these are kind of newer technologies that have come out over the last 3 years. The top picture is this Optilume. And Optilume was first created for men with urethral strictures, or narrowing of where the bladder meets the prostate, or the bladder meets the urethra, maybe after a surgery. And it's a balloon that dilates that space, and it has a drug that coats that balloon that kind of infuses into the tissue and prevents it from scarring back down. And so they took that technology and they're now using it for the prostate. It does require kind of making an incision in the top part of the prostate and then engaging this balloon. They just presented data for this at the Western Section AUA in October of last year. I think that people need to use it a little bit more widely. It's very new in its use before it takes on, but before a lot of urologists start to adopt it, but it's new and we'll see how it works. The next picture down here is this device called an iTind. This has been around for maybe 3 to 4 years. Essentially, we put this metal device into your urethra. It's deployed, and then it sits there. I want to say it's for 3 to 5 days, and then it's removed in the office. And it's felt that pressure causes breakdown of the prostate, to open up the channel. You know, I was approached by the company that makes this a couple of years ago. I've been waiting for it to take off in academic centers. I really have not heard any positive things. I think it's widely used in Europe, but I cannot imagine that it would be the most comfortable experience for a patient to have this in place. That being said, it doesn't require a trip to the operating room, and I may be proved wrong, and it might be the next best thing. And I'll find that out in a couple of years once somebody's done the research to prove me wrong. So I'm not offering this at this point in time, but it's definitely a new innovative technology in a way to target that prostatic growth. So what should you consider when you're trying to figure out what option to choose, or which surgery to choose? I think that things to consider: one, the amount of anesthesia, which I didn't put on here, or sedation that you need. So again, when I did the Rezum, I didn't do it in the operating room. I gave patients a Valium. So if you're not a great surgical candidate, that might be a good option for you. Or if you just don't want to have anesthesia. Again, it preserves sexual function. So is that ejaculation really important? Are you on the younger side and still hoping to expand your family? That's really important to preserve that sexual function. Or do you think you're going to be really bothered by having retrograde ejaculation? There are men who have told me I would have never had the surgery if I knew that this were going to happen. And then I have plenty of men who tell me I'm beyond my baby making years. It doesn't bother me. It happens with Flomax anyways. So, it's just, what are your priorities? I think length of catheterization is important. Again, some of those more minimally invasive procedures, it seems great, but then you do have a catheter for longer. And I will never minimize the frustrations and discomfort that comes with a catheter. Nobody likes it. It's an unfortunate means to an end, but it's important for your healing. It helps put pressure on where we just treated you, so it helps stop any bleeding. It prevents inflammation. It prevents scarring. So again, that may be from a UroLift that doesn't require a catheter at all, to the simple prostatectomy that's a 7-day catheterization. And then again, I guess this is the sedation, but that level of invasiveness, is it done in hospital? Can it be done in an ambulatory center, or is it done in the office? And where do you want it? Some people don't want to be awake. They don't want to feel anything. And then great, we do it in the hospital with sedation or anesthesia. Is it going to be endoscopic, which means my telescope camera? Or do you want to have that more invasive, most definitive surgery that's robotic? It's going to be very invasive. Does it require a stay in the hospital overnight? Some of these procedures are kind of newer, and that's why we're keeping patients in the hospital. We want to make sure that everybody's recovering really well. When I was in training, every person who had a TURP stayed in the hospital overnight. Now I send every patient who has a TURP, unless it's requested of me, home that same day. So these practice patterns may change over time, but if you don't want to be in a hospital because you have a dog you want to come home to, then maybe that treatment option is not great for you. And then the anticipated length of efficacy. So the Rezum and UroLift, the data says that they're very similar to a TURP at 5 years. I cannot argue with the randomized clinical trials, but I can say anecdotally, and when I speak to other surgeons and urologists, that data just doesn't hold up. My patients who had Rezum were back on medicine within 1 to 2 years. That's not my goal for you when I'm going to take you to the operating room. My goal is to have you off of medicine, really out of the urology office, except for our annual follow-up, for at least 5 to 10 years. And I would expect to see that with a TURP, with the aquablation, with a HoLEP, and a simple prostatectomy. And then again, like I mentioned, those other things to consider. So burning you're going to experience with any of these procedures. Some people will develop what we call de novo overactive bladder, which means increased frequency or urgency of urination after one of these surgeries. Oftentimes that resolves within the first 3 months. I like to give you time for your body to kind of heal from that insult from surgery. If it doesn't improve with conservative measures, meaning we avoid irritants to the bladder, I give you pelvic floor exercises to do, then at that point in time, we may need to consider medicines for you. Um, and then urge incontinence. So as of now, when you have that urge to go to the bathroom, you have a big prostate in the way. So it's going to take a lot of work for that urine to leak out. After surgery, you're not going to have that big prostate in the way. And so as you get used to your new anatomy, usually that is regained, that urge incontinence goes away. But it is something that some patients do experience, especially in the initial period of surgery. So those are definitely things that are important, though I don't think that they should deter you because typically they're temporary. So a lot of information, lots of different options that exist. So please share your questions with me.
Wonderful. Thank you so much, Dr. Locke. For those that may not have caught it in the beginning, you are welcome to ask questions. You can either enter them into the chat function or into the Q&A box, which you can find at the bottom of your Zoom screen if you hover over it. And there is an anonymous option if you'd prefer to ask that way. You can also try raising your hand and we can try letting you speak directly. And I'm just going to wait for those questions to come in. Remind folks that this is being recorded. So if you missed part of the webinar, you're welcome to tune into our YouTube channel and watch the webinar at a later date. So we'll just see if any of those questions are coming in. I think, let's see. One just came in asking, can you clarify again which procedures of the ones you discussed tonight are offered here locally at Barton?
Sure. So currently we offer the TURP at Barton. So that's the only procedure that I offer. We are looking to acquire Aquablation in the near future. And then again, I'm going to go to a training course for HoLEP and we'll hopefully offer that. In terms of the Rezūm and the UroLift, I don't feel so strongly about bringing them to Barton, so I don't offer them, but I can send you off the hill for that very easily.
Great. And then can you speak at all to, let's see, does BPH often result in higher stabilized PSA?
Sure. So your prostate is what makes PSA. So the larger your prostate, the higher your PSA may be. So I definitely have patients who have an elevated PSA and I have not been able to find prostate cancer. And so, the combination of their large prostate and their elevated PSA, we can say this is probably what's causing it. That being said, I would never tell a patient you have an enlarged prostate. I'm not going to further evaluate you for your elevated PSA. That makes sense.
Great. Can you speak maybe just on a high level to prostate cancer and things to be aware of?
Sure. So prostate cancer, unfortunately, like most cancers, it doesn't really cause symptoms when it's localized to your prostate. So a prostate is a continually growing organ. And unfortunately, that's where we tend to see cancers, where there's cell growth, and that gives the opportunity for a mutation. In terms of prostate cancer, they tend to grow on the outer part of the prostate, whereas the BPH grows internally. Prostate cancer tends to cause an elevated PSA, and so that's why we use that as that screener or that marker for prostate cancer. And we recommend screening at this point from ages 40 to 10 years left in life, which based off of the actuarial tables, no health information involved, is 77 currently. And that's that annual PSA. But unfortunately, there's not really a symptom that I have patients look for, because most men have no symptoms when it comes to prostate cancer, just that elevated PSA. When it's become more advanced, that's when we may see some of those more bothersome urinary symptoms, or fatigue, a decreased appetite, weight loss, more of those systemic symptoms.
And is there an age range that you recommend for screening? for
Yeah.
folks?
From 44 to about late 70s. Or sorry, excuse me, 40 to late 70s.
Great.
And yeah.
And one more, it just as far as like age range for starting to look for signs or symptoms regarding an enlarged prostate.
Yeah. So, I think that when you start to have urinary symptoms, which it can hit people as I'd say males as early as in their late 30s, early 40s, it's worth talking to your physician about. Sometimes it's not enlarged prostate. Sometimes it's that there's tension in your pelvic floor muscles, or it may be that the way that the prostate meets the bladder, it's at a hard angle, and that makes it more difficult to empty. But I'd say probably in the early 40s is when a lot of people start to develop symptoms. And then as we get into our 50s and 60s, they're very common, but I think everybody just writes it off as being normal. But it's not necessarily, even though it may be common or normal, it doesn't mean that it's great to have those symptoms, and you don't have to have those symptoms.
And this probably relates to the question that I just asked, but do you recommend, or do you also recommend a prostate exam starting at age 40 or just a PSA?
Yeah, so the AUA actually has kind of taken the prostate exam off of the prostate cancer screening recommendation. So it's now optional. I'm happy to do a prostate exam on men if they want me to when they come in, but it's really felt that the majority of prostate cancers are found through PSA. And if I can feel a cancer on my prostate exam, then it's probably locally advanced. So if you're staying on top of your screenings and you've started at a younger age, you likely don't need that prostate exam. Again, I'm always happy to do it. I don't think it's ever wrong to do it, but it's no longer a requirement.
Do you support biopsy and or MRI?
For a prostate cancer evaluation, yes. So typically when men come in with an elevated PSA, I always recheck it to make sure that it's not a lab error, or there was not infection or inflammation that caused it to be falsely elevated. If it's still high, then my typical recommendation is that we get an MRI. MRIs look for cancers that are clinically significant, meaning that they may spread beyond your prostate and affect your longevity, but they do miss 10 to 20% of cancers. So I still recommend proceeding with a biopsy. The benefit of having that MRI is that when we do a biopsy, we're kind of just taking very small needles and punching it through the prostate. So if I take a needle biopsy here and here, but your cancer is right here, I missed it. So the MRI gives a roadmap to help us find that cancer if it's there.
Great. I think that's the last of the questions I've seen, but I'll do my little end little wrap up. And if you have a question, I'm happy to still ask it. So make sure to get it in the chat box. But just as I said earlier, this webinar was recorded. We will have it available on our YouTube channel. We'll also put it up on our Facebook channel. And there will be a survey at the conclusion of the webinar. We love your feedback. How did we do tonight? And what topics would you like to hear from us in the future? And you know what? We have another question. So I'm going to go ahead and ask that. Is it true that when you have a problem with prostate, it might influence deterioration in kidney function? It's a good one.
Yeah, so let me see. I don't think I have any good images of the entire urinary tract. but I can show my jacket here. Maybe. So your so here's a nice picture of your kidneys. The ureters drain your urine from the kidney to the bladder. Here's your bladder and there's your urethra. So a male prostate surrounds that urethra. If you're not emptying your bladder well and you're retaining urine, sometimes what can happen is that urine can back up into your kidneys and cause kidney dysfunction. So when you come to my office and you're complaining of an enlarged prostate, I do typically have you pee for me, and then we scan your bladder to see how much is left over. And if it's, above a certain threshold and you're not ready to proceed with surgery, or we're not doing anything in the near future, I do recommend that we get an ultrasound of your kidneys to confirm that it's not causing that backup of urine, because that can cause kidney dysfunction.
Wonderful. Okay, well, I don't see any other questions other than just thank you for a great informative lecture tonight. I just appreciate your time, Dr. Locke, and everyone for being here. And I hope you have a wonderful rest of your evening. Thanks again.